Hitting 1. Thoracic trauma emergencies. 2. Critical head injuries. 3. The hidden bleed. And 4. Penetrating abdominal wounds.
All right, the ER doors are flying open, which brings us to Section 1, Thoracic Trauma Emergencies, focusing on airway and breathing. Let's go.
Here's your very first scenario. A 28-year-old male arrives post-road traffic accident. He's complaining of severe pain on the right side of his chest and extreme difficulty breathing. You look over at the monitor, and his respiratory rate is spiked at 26. He's got tachycardia, and his blood pressure is dangerously low. You see those vitals dropping fast, but what's your next move to figure out exactly what is collapsing this patient's lung?
Well, you percuss the chest, and boom, right there is the dramatic giveaway symptom. You hear a hyper-resonant note on the right side, coupled with decreased air entry. That hyper-resonant note, combined with the unstable vitals, absolutely locks in the diagnosis of a tension pneumothorax. What's happening is air is trapped in the pleural space, shifting the mediastinum and literally compressing the opposite lung.
Now the crucial point I want you to remember is right here. A tension pneumothorax is a clinical diagnosis. You do not wait for an X-ray to confirm this. You just don't have the time. While an EFAST ultrasound might show a barcode or stratosphere sign as a helpful adjunct, you have to act purely on your clinical findings right now to save this patient's life.
To save them immediately, you follow these exact steps for an emergency needle thoracocentesis. First, grab a wide-bore needle. Now pay attention to the updated adult guidelines here. You go straight to the 5th intercostal space at the mid-axillary line. For kids, it remains the 2nd intercostal space at the mid-clavicular line. You insert the needle, listen for that dramatic hissing sound of escaping air, and watch the vitals rapidly improve. Later, you'll move to definitive management by placing an intercostal chest tube in the triangle of safety with an underwater seal.
Suddenly, another patient rolls in, a 36-year-old with a penetrating injury to the left chest. Their Glasgow Coma Scale, or GCS, is totally fine at 14 out of 15. But just like our first patient, they have tachycardia and hypotension. They share those overlapping shock vitals. But wait a second, what is the key differentiator here to give us the actual diagnosis?
This is brilliant because it perfectly illustrates how to split the diagnosis between two overlapping chest traumas. You look really closely at patient 2. Instead of a hyperresonant chest, you see distended neck veins and you hear muffled heart sounds. This points directly to cardiac tamponade. Blood is filling the sac around the heart, squeezing it so tight it just can't pump. Again, this is a clinical diagnosis. You might use an EFAST scan to quickly spot the black, hypoechoic collection of fluid around the heart, but you have to move immediately.
With those muffled heart sounds identified, you've got to execute these steps for a needle pericardiocentesis, ideally under ECG or echo control to avoid arrhythmias. First, locate the left costoxiphoid angle. Go in at a 45-degree angle and direct your needle toward the left shoulder tip. You slowly advance while aspirating until you feel a slight loss of resistance. Honestly, pulling out even just 5 to 10 cc's of blood is a total game changer. It will dramatically improve the patient's hemodynamics before you rush them to the operating theater for a definitive pericardial window.
Okay, let's see how the stakes change as we transition to Section 2, critical head injuries, focusing on disability.
You're taking the history from the paramedics for patient 3. A young batsman was hit on the head by a high-velocity ball. They described this terrifying back-and-forth sequence. He lost consciousness briefly, woke up and seemed completely fine, but then, right on the way to the hospital, he lost consciousness again. This back-and-forth state, known as the lucid interval, is your massive, glaring red flag for an extradural hemorrhage, or EDH. This usually means the middle meningeal artery has been ruptured. You rush them for the investigation of choice, which is a non-contrast CT scan. You're looking specifically for a biconvex or lens-shaped hemorrhage. This is totally distinct from the concavo-convex shape of a subdural bleed.
If that scan confirms an EDH, you need to look really closely at the sizing. These are the precise, non-negotiable thresholds that dictate rushing this patient immediately to the operating theater for a craniotomy. We're talking a clot volume over 30 cc, a midline shift of more than 5 millimeters, or a clot thickness greater than 1.5 centimeters. Hit any of those? Surgery is absolutely mandatory.
Next up, we face honestly the most confusing scenario of the night. A 22-year-old male comes in post-RTA. His GCS is E2M2V2, making a total of 6. Anything 8 or below means the patient is in a coma. He has no fractures, you get the non-contrast CT scan, and it is absolutely, completely normal. Yet, his GCS isn't improving at all. So, what on earth is going on? This mismatch is the classic hallmark of a diffuse axonal injury. The initial CT looks completely normal, but the massive shearing forces from the trauma have literally torn the brain at a microscopic level. To actually see it, you need an MRI. That's going to reveal tiny punctate hemorrhages exactly at the junction where the gray and white matter meet. Because of this widespread hidden damage, it carries the absolute worst prognosis among primary brain injuries.
Moving on through our shift, sometimes the numbers just don't match the visual evidence. Let's look at Section 3, the hidden bleed, evaluating circulation.
Patient 4 is a 24-year-old who says he hit his head in a crash. His GCS is 12, so he's awake. But you check his pulse, and it's a rapid 110, and it's very feeble. His jugular venous pressure is low, and his systolic blood pressure is dropping to 90. He's in Class 3 hypovolemic shock. But you examine him, and there is zero visible bleeding, no lacerations, and no fractures anywhere on his body or his head.
Okay, listen to me. Here is a golden rule in trauma. An isolated head bleed will not give rise to hypovolemic shock. A bleeding brain simply does not have enough volume capacity to drop the entire body's blood pressure to 90. So, if they are in hypovolemic shock without external bleeding, you must immediately search the neck, the thorax, the abdomen, and the pelvis.
To find that hidden internal hemorrhage, you grab the ultrasound probe and perform a fast scan, following this exact sequence from the ATLS guidelines. Epigastrium, right hypochondrium, left hypochondrium, and finally the suprapubic region to look into the pelvis. If you're doing an extended fast, or EFAST, you add the thoracic cavities. You are hunting for that telltale black, hypoechoic fluid.
Your fast scan finds the culprit, a massive bleed in the abdomen from a shattered spleen. Tracking the life cycle of this care, the emergency phase demands IV fluids, antibiotics, and rushing them to an exploratory laparotomy. Definitively, a grade 4 unstable splenic injury usually means a splenectomy. But look closely at the post-op care. On post-op day 1, the patient develops a fever. Don't jump to opportunistic infections. Actually, the most likely cause on day 1 is atelectasis. That means collapsed alveoli on the left side due to shallow breathing from the pain. You treat this simply with incentive spirometry and chest physiotherapy.
Finally, we face our last patient of the shift in Section 4, penetrating abdominal wounds, dealing with surgical emergencies.
A 29-year-old male is brought in after getting into a fight and suffering a stab wound to the abdomen. You check his vitals, and surprisingly, he's completely stable. Heart rate is fine, blood pressure is fine. However, when you inspect the wound, a tag of omentum tissue is visibly protruding right out of the stab site. Now, the patient seems perfectly stable, so the question is, can we just bandage this up and observe him conservatively?
Absolutely not. Because that omentum is protruding, the peritoneum has clearly been breached. Conservative management is completely out the window. There are 4 mandatory triggers for an emergency laparotomy in a penetrating abdominal wound: unstable vitals, bile staining on the dressing, protruding omentum, or clinical features of peritonitis. Hit any of these 4 and you must rush them straight to surgery. No exceptions.
And just like that, our shift comes to an end. We've navigated tension pneumothorax, tamponade, hidden splenic bleeds, and severe brain injuries. By mastering these 6 high-yield trauma presentations and understanding the structured logic behind the clinical signs we've explored today, you're not just learning medical concepts, you're preparing to make the exact calls that save lives when every single second counts. It begs the question, next time you look at a seemingly stable patient, what hidden, microscopic, or internal trauma might you be missing right beneath the surface?